Thanks, sir. Thanks.
I think you are the one who visited Hubli compared to others.
Yes, yes, yes.
Yes. Hope you had good time here.
Yes, Hubli is nice.
Yes.
Sir, with your permission, we will start now, sir. Good evening, friends. Good evening, friends, senior professors, faculty joined in the Zoom, and people who have joined in the YouTube. We warmly welcome for you to. Can you please unshare for a moment, Abhijit? So we are here to thank all of you for helping us to achieve one major milestone. We are now close to 420,000 views. That is after the 4 lakh views, which I announced a month before. And I'm here also to thank and inform everyone that we have subscribed viewers 12,500. And I could see another 6,000 people who visit us without subscribing our channel. So we thank both the subscribed and unsubscribed students for joining us at your convenience and getting benefited of it. Friends, we have 370 cases, and this is 176th session going on, the grace of God, and it's been no looking back. Some way or other, in spite of difficulties, every session happens with the help of all the faculty here. So we have 2 important presentations. One case is thyroid case. Is kindly contributed by Professor Jishan Ahmad ma'am. She is the president of the Department of Assam Medical College at Dibrugarh. And we have the other case kindly contributed by Smriti ma'am. She is from HPT Medical College and R.N. Cooper Hospital, Mumbai. This is Dr. Sushant Babal. So we will have the first case, the thyroid. Can we have Abhijit Patra? Abhijit Patra, please introduce yourself. You are unit chief, you are head of the department, and start your presentation. Good luck to you.
Unit chief question.
Your unit chief.
Good luck.
Good
Good evening, sir. Myself,
Sir,
Dr. Abhijit Patra. Good evening, teachers, faculties, and my dear friends. Myself, Dr. Abhijit Patra from Assam Medical College in Dibrugarh. Today, I am here to present a case on thyroid.
Okay, no unit chief.
Now coming to the history, my patient name Kavita Sharma, age 39 years, sex female. Now address, she is a resident of the Jonai Dhemaji. Occupation, she is a homemaker. By religion, she is Hindu, and education qualification is at class 10 pass. The date of admission of her in our college is on 21st of March, and we have examined the case on 23rd of March. Now she came with the chief complaint of swelling in the right side of the neck for 4 months. On elaborating the history and the history of the present illness, my patient complained of swelling on the right side of the neck for the last 4 months. Before that, she was apparently normal. The swelling was sudden in onset, which was about 3 centimeter into 2 centimeter. 3 centimeter is the vertical dimension, and 2 centimeter to the horizontal, according to the patient, single in number. From the first time she has failed, and it remains static till death. Now, the swelling is not associated with any pain, fever, hoarseness of voice, loss of weight, or dysphagia. There is no history of intake of medications, change of body weight, sleepless nights, tremors, and the palpitations and weakness of the body. The patient does not give any complaint, no complaints of double vision, chest pain, loss of hair, and altered bowel habits, and the joint pain and muscle weakness. Now, the past history. The patient is on hypertensive for the last 2 years on irregular medication with no significant illness. There is no history of diabetes or any history of operative intervention. Now, family history. Her family consists of 4 members, her husband and 2 children delivered in the normal vaginal delivery. The patient does not give any history of major illness in the family. The personal history: the patient lives in the Pakka house and drinks water from the municipality supply. After proper boiling, she consumes mixed diet of veg and non-veg. She neither consumes alcohol nor any tobacco-related products. The menstrual history: she is attained her menarche at the age of the 14 years and having the regular cycles of 30-day period. The duration was 4 to 5 days without any pain, and the amount approximately 30 to 50 ml. Immunization history: the BCG mark was present, while complete immunization history cannot be elicited as the patient cannot remember that full immunization history of her. Now, further going to the general examination.
Go to history of.
Hang on, Dr. Abhijit. The question
Yes,
here
sir.
on your history, please. Okay.
History of
You said
illness must go in an order, saying
Right.
what will be the possible complaints a patient who got a swelling in the thyroid region will have. All those things you have to rule out. First one. Number two, you have
The
to
horse.
rule out complication features by questioning. Some features will be told by the patient. The remaining you
Yes,
have
sir.
to list it. Similarly, in between the hyperfunction, hypofunction features, you can put it in a nutshell, say that there are no hypofunction features. There are no hyperfunction features. If they are present, you say that there are hyperfunction features like 1, 2, 3, like that. Similarly, the pressure symptoms you have to mention in the beginning. Is it clear?
Okay, sir. Yes, sir.
Dr. Abhijit,
Yes, sir.
you said swelling on the right side of the neck. It
Yes,
would be
sir.
better. It's a thyroid swelling, isn't it?
Yes, sir.
So you just say in the thyroid region rather than, you're a surgeon, right? It's not an MBBS exam, right? So just say that in the thyroid, in the center is in the neck, in the thyroid region, right? Now in thyroid, you got to rule out function and whether it's benign or malignant.
Yes, sir.
So your history should be divided into these two parts. You can't just shuffle pain, fever, hoarseness, loss of weight, dysphagia together, right? Or you just
Yes,
say,
sir.
like Sir said, Professor Jawahar said, just say patient is does not seem to have any features of hyper or hypothyroidism. Does not complain of, right?
Yes.
Just next slide, sir, please.
Abhijit, what Sir said, Raju said, is the front and right side of the neck would have been better. Front of the neck. Even if you mentioned the front of the neck in the region of the thyroid, it is more acceptable. One thing. And the second thing, you mentioned the religion Hindu. It doesn't mean anything for the thyroid disorders. One, you not mentioned about the religion in this case. Then third point, you mentioned about the sudden in onset. How often the thyroid swelling patient will be noticed suddenly?
Sir, the patient came with that she failed a mass 4 months ago.
That means
After
you
that,
must say
she was in the.
patient noticed the swelling. You should not say
Yes,
sudden
Yes,
onset.
sir.
Sudden
Sudden
onset.
means,
Notice the swelling.
sudden means that she saw there was nothing there yesterday and suddenly she saw it. Okay.
Yeah,
Next
but
one.
she felt at the first time, sir. Suddenly
No, so it's not suddenly. She
He
notices
noticed,
for the first time.
not
noticed
onset.
for the
Not
first time.
onset time.
If you see that your forehead is flat and tomorrow you have a swelling, that is sudden, right?
Yes. Then one more thing, you mentioned no history of pain. Okay. So my question is there any thyroid swellings which can have a sudden in onset, which can present it with the pain?
So cervical thyroiditis, acute thyroiditis.
Yeah. So usually the inflammatory conditions of the thyroid, they can have a sudden in onset. The patient may not have noticed 1 or 2 days before. Then hemorrhage in the very small thyroid swelling, which has been not noticed by the patient, it can be suddenly, she must have noticed. So usually they are associated with pain. In your case, you have mentioned clearly that it is no associated with pain. So obviously it rules out the possibility of an inflammatory swellings. Then you have mentioned about the toxic symptoms, which is okay, appropriate. And then you mentioned about the municipality water. What do you exactly want to convey?
Sir, he used to take from the
No.
supply water on.
What
Nothing
is
was
your
given,
idea?
sir.
Idea of putting this, where the water comes from, which water it drinks? What you would like to convey to us?
So there may be iodine deficiency in the water.
Yeah, so you could have straight away put it as, so there's water is coming from that. Your idea of putting this is patient is taking water which is well iodinated. That's what you wanted to convey, no? Okay, acceptable.
sir.
Then when you mentioned about the immunization, then what way it is related here? Immunization, certain history you need not simply shouldn't ask such cases. How it immunizations in relates to your thyroid swelling?
Abhijit, when you're sitting in the OPD,
Lymph.
Abhijit, when you're sitting in
Yes,
the
sir.
OPD and you have a patient of thyroid, do you go through this all rigmarole of immunization and all that? So it's not like that. This is a surgery exam. So this is there for MBBS, or if there was something related to immunization, you could have, like COVID or something, then you could have mentioned it. It doesn't matter here, right? So don't go by the book. If someone asks you, you can mention.
Abhijit, better, see, you have presented well, but please do not say like sex, female, age, this, not in a telegraphic language. If you can present like a sentence, that will always have a positive mind. That means you are confident and you are very good. Instead of putting it in a what sex,
Tabulated
age,
form.
a telegraphic language. You, sir, all were talking about thyroid region. What do you mean by thyroid region?
So it extends from the below the thyroid cricoid cartilage, between the cricoid cartilage and the thyroid.
That is not the problem
region.
comes. No, what
Sorry,
is the
sir?
definition? What is the boundary of thyroid region? Once you do not know that, you will only go for the right-sided, left-sided, and all that things. What is the boundary of thyroid region?
It extends from the thyroid cartilage to the cricoid region.
Cricoid
What is the lower? Why? Upper limit is acceptable. What is the lower limit?
Lower limit is
tracheal rings of 3, 4, and 5.
No. You don't see the L4, L5 and all here, no? T4.
Clinically.
The anterior side, you must sleep when the even thyroid cartilage is quite big. So you must say the upper border of the thyroid cartilage or the oblique line of thyroid cartilage and sternal notch are here.
Sternal notch.
And on either side, you must see that if you know the specific side, that you will not go wrongly on that. And you said acute thyroiditis. Is it common in thyroiditis? Acute thyroiditis is common in thyroid?
No, sir.
Do you get acute
infective, or there if there is any thyroglossal tract patent, then in that cases we can get the acute thyroiditis.
Thyroglossal cyst will not produce a thyroiditis.
Any fistula or something like that, sir, which can lead to the infection origin.
No, it cannot produce. Huh? The thyroid is protected from infection. What are the ways how it is protected? Why infection is not common in thyroid? Inflammation or infection is not very common in thyroid.
Capsule, for the capsule, which is
one is capsule. Anything else? No.
Blood supply, does it matter?
Yeah. Blood supply, yes, it's a high flow. So
high flow blood supply is
will only advise and request the PGs. No, at least you go back, because all the 300 videos are there in the YouTube. Just go back. What are the common questions which is being discussed? Because now again it seems we are starting on the fundamentals. Basic things that if you go the PGs postgraduate presenting, if you can prepare on that and come, it will be all beneficial for all the people. And all this something like loss of hair. And how do you ask the history of loss of hair?
So if there is a hair fall, sudden increase in the hair fall, or there or not?
These are very, very vague questions and specific to you, because you are presenting as if in a style. You started in a way in the swelling, but rest related to the thyroid, not much you have asked. You have gone astray and asking a lot of other questions like vaccination, other things. Please try to focus on your case, focus on the disease with which the patient has come to you.
Yes,
What
sir.
is given in the Das book, you can follow that. It will be enough.
You
You are
are
presenting
not.
for the first time, Abhijit. You are
Yes, sir.
presenting for the first time.
In
Are you
online,
pres-
yes, sir.
Yeah, no problem, no problem. These are all corrections by the teachers. Okay, don't get
Yes.
so that is correcting you. Certain things are not needed. So when you present in your final exam, you can omit all these things. When you prepare a PPT, what all has been told now, and correct and keep it. Okay,
Yes, sir.
right.
Go ahead with the
I
exam.
mean, you have mentioned about family history in this case.
Yes, so there is no any significant family history in this. Yes.
What
Which
is
are the thyroid?
significant? Then
which are
we
the
have to ask you what is significant in the family history.
So if there is in
You always see any
See-
similar
see,
in the family.
thyroid
See, you have
swelling in
mentioned
the
about the
family or in the enlargement of the other people in the family, gland enlargement in the family, then there may be iodine deficiency also can be present. Or if any patient has for thyroid malignancies also,
What are the familial conditions you can get in the thyroid?
MEN syndromes, MEN 2A, MEN 2B,
What is meant to a?
RET. If there is any rate mutations, there are no
What
many.
are the components of meant to a?
Combinations. That is what Sir is asking.
Sorry, sir.
What are the
2A
components of meant to a?
There will be pheochromocytoma,
Your patient has
pheochromocytoma, parathyroid CAs, and there will be medullary thyroid carcinomas.
thyroid CA.
Hyperparathyroidism, sorry, sir.
all P. You know, in 2A, all starts with the P.
You have your patient has a history of hypertension. Do you think any relation to that hypertension and thyroid?
Pheochromocytoma.
So when your patient history gives the hypertension, you should always have that in your mind. It's not that very common, but still you should think of that possibility.
Yes.
What is endemic goiter?
Sorry, sir.
Endemic goiter.
Symptomatic goiter.
Endemic goiter.
And no, sir. There is no any endemic goiter history in the family.
No, what do you mean by that?
What do you mean by that? That's what I'm asking you.
Endemic goiter means there is in the regions where the consumption of the cabbage or some, and in the Himalayan regions, there is a deficiency of minerals in the deficiency of the minerals in that region, so which leads to the goiter in the endemic region, with the iodine deficiency is less in those regions.
We don't want such an elaborate answer. Whenever I ask what do you mean by endemic goiter, you have to mention the simple words. There is increased incidence of a goiter in the fixed geographical area. The reason what you are given is right, but what the question is asked is not the answer for that. Okay, sir is asked only what is endemic goiter.
When you talk like this,
then,
what other questions will be asked? You said cabbage, and what does the cabbage cause?
The
cabbage cause iodine deficiency.
What is the pharmacological agent which can cause the
cyanates?
What cyanates?
Thiocyanate. Thiocyanate, not cyanate. It contains thiocyanate-like substances which acts like an antithyroid drugs. Okay, just they'll have an increased incidence in a family who consumes a cabbage. Okay. Then in the family history, you also not mentioned about possibility of enzyme deficient goiters could be there. One possibility. One is malignancy is one possibility. Another is autoimmune disorders also can be familial. So you have to keep these are 3 to 4 disorders in common whenever you are asking a history of a family history. Then one more you have not mentioned, history of radiation. Is it important in this case?
Yes, sir. There is a radiation induced. Some cancers are radiation induced.
Okay.
Type
So
of
you are not
radiation?
mentioned in the.
What type of radiation? How will you ask the history for that? What are the conditions they would have subjected to the radiation?
Any other for any other reasons
just
also the radiation, lymphomas or something?
Yes. Yes.
Okay.
The patient would have been received radiotherapy for a lymphoma in a childhood or in a younger age group. So they are very high increase of radiation-induced thyroid swellings. Okay.
Mention it as childhood irradiation in the past history.
Yes.
Really, what is the condition called the goiter running in family, in one family? Is any specific name we call it? It is called familial disharmonigenesis. That you have to mention in the conditions which runs in family. First you tell benign and then go to malignancy. Straight away you don't start with the MEN.
So I have no idea, sir. Family.
No, where the converting enzyme is deficient in that family, that produces familial disharmonigenesis, producing goiter. Is it okay, sir?
Peroxidase.
Okay.
So it is asking which enzyme is responsible for the enzyme deficient goiters.
Peroxidase.
If you tell that name of the peroxidase enzyme. What is the mechanism? Can you tell me in one word how it causes the deficiency of thyroid hormones?
So,
what is its role? What is its role in the synthesis of a thyroid hormone?
Organification of the thyroglobulin.
Thyroglobulin.
Sir?
Thyroglobulin organification.
So I didn't get the question, sir.
No, you must know the steps correctly and say that what is the step we are.
First, the iodide has been through the sodium iodine pump. It has been taken up by the gland, which has been converted to the iodine. And then the iodine.
It is
known as
not
the trapping,
like what you are saying for an undergraduate level. In a postgraduate, should say exactly how you are reaching the gland and what is happening into the gland. Each steps are important. Each enzyme involved is important.
At first, we consume the iodine, which gets into the jejunum, which is converted to the iodide and gets absorbed. From the iodide, it's go to for the blood circulation. It goes to the gland, which has been taken up by the sodium iodine pump, which gets converted. In this way, we trap the iodine. Again, in the gland, the iodine gets converted into the iodide gets converted into the iodine.
Iodine, yes. This is the first step, which requires a peroxidase enzyme. What is the next step?
Then comes the peroxidase enzyme rule, sir, which gets into the thyroglobulin, which makes the mono then di, then which get combines. We combine with the T3 or T4, which released in the maximum of the amount has been released into the blood as a T4. And there is also some amount of reverse T3, and T4 in the periphery gets converted into the T3, which is the active form, sir.
Which is the active form? T3.
T3 is the active form, sir.
What is? Can you put it in single word? Whatever the mechanism, what you described in a single word. What you mentioned is entire process is coupling. Yeah, it is entire process is a coupling in one word. What you described is absolutely correct. Okay.
What is the difference between T3 and reverse T3?
Sorry, sir.
Reverse T3.
Reverse.
Okay.
Is the only so enzyme you want to use? Which one? I didn't get the questions actually.
There is a T3, and we also have a that called reverse T3.
Yes, sir.
So what is that difference you are getting?
So the binding of the iodine to the molecule, it is the 3,3 and the 1,3 actually. The position actually.
Not 1,3.
The binding to the
5. Always it is 3 and 5.
Sorry?
3 and 5.
Yes, sir. 3 and 5. Sir.
If it is from the outer layer, if the one molecule is removed from the T4, then you are going to get a T3. And if it is going from inner molecule, you are going to get a reverse T3.
Yes.
Okay, go ahead with it. The clinical exam.
what do you think with this history? Whatever the describe you are given.
Yeah.
What is your the possibility of diagnosis on history level? History level.
Sir, it may be a simple cyst.
First you say the anatomical diagnosis, then you go for pathology.
Anatomically, sir, it's a thyroid gland.
What makes you
Because
to
of
say
the
it's
region.
thyroid? What makes you to say it is a thyroid? Because you are saying only right side of the neck, right side of the neck.
On any, yes, sir.
I was thinking
Any
it is
lymph node.
Okay. So any point for you to say it is a thyroid only in the history?
That you
So
described
exactly,
it as
it's
on the right
very
side.
difficult. Exactly, it's very difficult to say because it may be a lymph node also. It may be a thyroid cyst.
But you have never
gland.
asked any questions related to lymph node. When you are thinking it is a right-sided lesion, could be a lymph node. You are not asked any questions related to the drainage site of the lymph nodes.
No fever, no
You're supposed to
pain.
ask is no fever, no pain, no ulcers in the
No
body,
night
no
sweats.
difficulty in swallowing, no nuts. So many questions you would have been asked if you are thinking in terms of a lymph node swelling.
Oh,
Yes.
now you
You
are
have to
thinking
think possibility of a
thyroid.
metastatic lymph node. Okay, okay. Continue the examination.
So on the general examination, patient is conscious and cooperative, well-oriented to time, place, and person. The average built on the build was average and nourishment, and the BMI is 21 kg per meter square. The temperature which we got is a 98.4 degree Fahrenheit in the right axillary region, and the BP was 110 systolic and 70 diastolic millimeter of mercury in the right brachial artery at the in the lying supine position at the chest level we have measured, and the pulse rate is the 92 beats per minute, regular in rhythm, normovolumic, normal in character, palpated in the right radial artery without any radial and the radiofemoral delay. The oxygen saturation was 97 at the room air. The pallor, it is absent. Icterus, clubbing, cyanosis, lymphadenopathy, and the edema and the tremors are absent. Now going to the local examination on inspection.
Examination, how did you measure the radiofemoral delay? What is
Sir, both the pulses has been simultaneously we take in the hand, we place one hand in the we place one hand in the radial
what is the
artery and
significance
one hand in the femoral. Sorry, sir.
What is the significance of radiofemoral delay and radial delay in a thyroid swelling?
Compression, in case of the compression of the carotid region or the subclavian region.
Thyroid in subclavian region.
No, sir. Sorry, sir. In the carotid sheet, if they extend into the carotid sheet, then
you will get a radiofemoral delay.
No, sir.
Why? What is this? There is no necessary for you to spend. You are only going to given only 40 minutes time for examination. Don't spend your time for unnecessarily doing all these not necessary tests and presenting like a medical student. All that is not necessary. You as a postgraduate, try to present relaxedly what you are exactly doing in the ward. That is what we are interested. Then you are saying exactly in a supine position, chest level. That's all. We don't expect for a postgraduate. You don't think that you will not know how to take a BP. So take the BP is this. Go to the proper thing. Don't spend your time in unnecessarily in other areas.
As far as thyroid is concerned, as far as the pulse rate, you have to rate rhythm, collapsing and non-collapsing. These are good enough. Then you are wasting your time in wasting so many things. One more you mentioned about SpO2, 97% at room air. Why it is important? It is not at all required at all.
Okay, sir.
Yeah, the significant is 92. Pulse rate is 92. So that is significant.
Yes.
What are the abnormalities in the pulse you can get in the thyroid?
So resting pulse will be increased.
Oh, on examining the pulse.
Sleepless in the sleep.
We are not asking
Sleeping
the sleep.
pulse.
Yeah? The normal pulse. What will be the pulse if it is a thyrotoxicosis?
Tachycardia, sir.
Only tachycardia. What is wide pulse pressure? What is brachial dance?
Pulse pressure will be increased.
Okay.
Wide pulse pressure.
So you must know the changes, not only in the number. This tachycardia, it will be there. But when there is a Graves' disease or thyrotoxicosis, other changes can be also there. It's a hyperdynamic circulation. So other changes in the arteries, pulse will be also there. Since you are going to everything in details, so the more questions will be asked on that, pulse and other things. Go ahead.
So can go ahead.
Yeah, please.
Yes, examination.
Look, on going to the local examination. Now inspection, the site is in the right side of the neck, 4 centimeter above and 2 centimeter lateral to the sternal notch. Now color, there is no change of the color is noted. This shape is spherical. The size, it is a 3 centimeter in the vertical extent and 2 centimeter the horizontal extent, which is smooth, edge indistinct, move upwards with the deglutination, but no significant movement with protrusion of the tongue. The pulsation, it is absent. Impulse on coughing, it's absent. No dilatation of the veins in the neck noted, and no sinuses or the fistula is noted. Now on palpation, the local region, no local rise of temperature and the tenderness noted. The swelling is 3 centimeter vertical, 2 centimeter horizontal noted over the right lobe of the thyroid gland, spherical in shape, smooth in surface, well defined edge, and mobile in both horizontal and vertical planes. And swelling moves with the deglutination. Now cystic inconsistency, non-fluctuating, non-reducible and non-compressible, no retrosternal extension. Position of trachea is in the midline, no pressure effect noted. Now on the percussion, it is the dull note present over the gland, no retrosternal extension noted. On auscultation, no brood noted, and the eye signs were absent.
Go to inspection.
Vijay,
Yes, sir.
In
you have a lot.
So mention about position of trachea. Is the lower border seen or not? All those things you have to mention on inspection. Then you have to mention about the position of the patient and your position.
We position examined on the sitting position and
During inspection, patient is made to sit and you are standing in front of the patient. During the palpation, you are supposed to go back to the patient and examine.
go back.
That's
Sir.
what sir expected.
Yes.
Okay. Then there are so many wrong things which are mentioned in inspectory findings. So when you mentioned it is a spherical swelling, it cannot be spherical swelling. It is an hemispherical swelling. Then the dimensions which you have mentioned 3/2. 3/2 dimensions cannot be a hemispherical or spherical. Okay. These things you should be very careful about that. Then you have mentioned cystic inconsistency, non-fluctuating. So there are so many contradictory are there in your palpatory finding also.
Cystic means it might be fluctuant, you know.
Fluctuating.
Yes, sir.
Petra.
Okay. So,
Impulse on coffee, what do you check? Impulse on coffee? For what you checked?
Is there any significant enlargement in the impulse of coughing?
Thyroid.
the swelling which you mentioned moves with the deglutition. Is there any other swellings which moves with deglutition have an impulse on cough? That's what sir is expecting.
Yeah, not the thyroid.
Yes, sir.
Any swelling in the neck, you think of impulse on coughing is positive.
Coughing.
Burst side.
Okay. Any zeal?
Laryngoscele. Laryngoscele.
So what laryngoscele? Internal or external laryngoscele?
External, sir.
So you must know all that things. Why do you want to bring impulse on coughing? Thyroid, we know, but don't do that. No?
Okay, sir.
We said moves with deglutition. Can you explain the physiology on that?
Sir, due to the attachment of the pretracheal fascia
Attachment of what?
and the deep cervical fascia and the Berry's ligament.
Don't say in a telegraphic language. You say continuously. What do you mean by that?
Continuous.
What deep fascia?
Sir?
No. What do you mean by that pretracheal fascia attachment?
So it is a continuation of the vertebral fascia which extend.
So what happens to that?
Sir, there is an uplift. Yeah.
Why there is an uplift?
Thyroid capsule attached to the berries, then it is around the fascia. That's why, sir.
No.
You must know the plane of the swelling. What is the covering called? Or the layer called? That is what sir is asking. Then go to Berry's ligament. Straight away you cannot go to Berry's ligament.
What is the Berry's ligament?
Capsule, from the capsule only it is attached, sir.
Pseudo capsule or true capsule?
True, sir.
True capsule. So true capsule is found by?
Pretracheal.
Use the word investing layer of deep cervical fascia.
Investing layer of the deep cervical fascia.
Where is it attached? Berry's ligament?
So posteriorly, sir.
Posterior to what?
Posterior to Berry's ligament.
Okay.
Is it superior or inferiorly?
Sorry, sir. Superiorly,
Is
sir.
it superior attachment?
Superior,
attachment. It is a posterior superior to the gland. From
Yes,
there it
posterior.
starts and gets condensed and gets attached to the cricoid cartilage. This cricoid cartilage moves with deglutition. As a result, this thyroid swelling also moves with deglutition. Your answer would be very precise. The pretracheal fascia, which is nothing but the condensation of the deep cervical fascia, which invests the gland. Okay, it condenses to form a Berry's ligament at the posterior superior border of the thyroid cartilage. It goes and gets attached to the cricoid cartilage. Since the cricoid cartilage moves with deglutition, because of this also the thyroid gland moves with deglutition. Your answer has to be in continuation and precise. You understood, no?
No, because many
Yes,
times
Yes, sir.
postgraduates think that this is not a very common question, because though we presume that you know, but we expect you to explain it in a proper way.
Proper way.
What are the various ways to know the position of the trachea?
Sir, first we've placed the 3 fingers
Okay, so
in
that
the
is the
region.
palpatory method.
The middle finger.
What
So
are the
with the
other
3
ways?
finger with. Sorry, sir. And with
What are the other ways apart from this 3 fingers test? What are the other
by
ways?
placing your stethoscope in that region,
Yes.
bell of the stethoscope,
Right.
Can you have any inspectory
Can you
finding?
tell on inspection
in
that
the chest and X-ray also. So yes, sir.
Inspection.
on inspection, can you tell whether trachea shifted?
Inspection.
You heard trail sign?
Real sign.
No, sir.
Prominent sternocleidomastoid. If you find on one side, there's a prominent sternocleidomastoid is there, the trachea shifted to that side, Jay. Okay.
Okay, sir.
Did you palpate the carotid pulsations here?
Yes, sir.
Where did you feel that?
So lateral and the sternocleidomastoid in the anterior border of the sternocleidomastoid, sir.
Sternocleidomastoid is a big, long structure. So where you
What level?
Upper, middle, lower.
Level of the cricoid, sir.
What is that level?
C2.
Against which
C6.
vertebra you are feeling? Tubercular, which vertebra?
C3, C5, sir. C3 to C5.
C6. You are feeling it against the C6. And it is the middle part of the sternocleidomastoid which is there. There you are going to feel it with that. So which carotid you are feeling?
External carotid, sir.
At that level you are feeling the common carotid.
Common, sorry, sir. Common carotid.
Yeah, if you have to feel the external carotid, you can feel it at a higher level. Can you feel the internal carotid?
No, sir.
If you have to feel the internal carotid, where you will feel it?
By any chance, any disease, you can see that internal carotid. Where you will look for seeing that or feel that?
Glomastoid. Glomastoid.
Feel it at the tonsillar fossa, okay? If you have to feel the internal carotid artery, you can feel it at the tonsillar fossa. Is your swelling related to sternocleidomastoid, superficial or deep?
Superficial.
Superficial to sternocleidomastoid?
Sorry, sir.
What is the relation?
What is the relation of this swelling to the sternocleidomastoid? Thyroid swelling to the sternocleidomastoid.
It's anterior to the sternocleidomastoid, sir. Anterior medial.
It will never come anterior. Right? Whatever the size of the thyroid swelling will be there, it will never come anterior to the sternocleidomastoid. It will always go posterior to the sternocleidomastoid. Okay, so you can blindly say that this swelling, if it is there in that area, it is deeper to the sternocleidomastoid.
What are the other landmarks you have in the cricoid cartilage level? Any important landmarks? C6 level. So that is the level where the pharynx becomes the esophagus. That is the level where the larynx becomes the trachea. Only below that level, you get the trachea and esophagus. You have only 4 to 5 tracheal rings in the neck.
Yes, sir.
Oh. Where did you auscultate for the brew?
Over the swelling, sir.
No, like if there's a big thyroid is there, where you will auscultate?
Superior border, inferior border, or middle portion of the thyroid, where you would like to auscultate?
Superior borders.
Why?
Why superior border?
Because of the vascularity.
Inferior thyroid is
superior thyroid. Superior
is it
thyroid
because of vascularity there or something else? Because inferior thyroid artery is almost equal to the superior thyroid, or even slightly bigger than that. Superior thyroid is superficial, okay? It is lying right at the superior pole there. While inferior thyroid comes from the behind the carotid sheath. And then it supplies in that area. Okay, so it is never at the lower pole. It is 2/3 and 1/3 junction, which is there of the thyroid, it will be there. So that is why you always auscultate over the superior pole here.
What is the artery coming in the lower pole?
The inferior thyroid and the thyroidema artery, sir.
Inferior thyroid comes in the lower pole. You remember the direction of the inferior thyroid artery. It comes from lateral and comes around, enter into the thyroid at the mid level. It will not come to the lower pole. But superior thyroid will be there in the superior pole.
And where is the inferior thyroid vein? Is it traveling with the inferior thyroid artery or not?
Artery and vein,
Yes,
are they both together?
Do they travel together? Superior and the inferior.
Vein, sir.
Superior
No.
artery and vein, they are
Superior travels together, sir. Inferior doesn't travel together, sir.
So where is the inferior thyroid vein?
It comes through the middle portion, sir.
No,
That
it
is
is at
artery.
the lower pole, jo hai na?
Vein comes in the
Inferior
lower.
thyroid vein is at the lower pole, but inferior thyroid artery is on the side, jo hai na? Okay. Okay.
Continue the next step.
You have percussion on the thyroid gland. No?
Sir?
The percussion part, next slide.
Percussion? Sorry, sir.
Next slide you put.
Next slide.
Next. A dull node present over the gland. What do you mean?
Sir, there.
Is it necessary anywhere you said the percuss on the
No, sir.
thyroid gland? Kind of what you are expecting? It will resonate sometimes. Do you have any-
External extension is necessary, sir.
No, for that you are going to percuss on the thyroid.
No, sir. Start now.
So you are here the percussion. You are expected to do only a percussion on the sternum,
Yes, sir.
not assess the dull node on the thyroid. Is there any condition where the thyroid will be resonant?
Thyroid resonant.
No, I'm not. I'm just asking you. I do not know.
No, sir. I have no ideas. No, sir. No resonance can be present.
That's why no need to go for do the dull node present over the gland.
Yes.
You can do the dull node.
There is no examination of percussion on a thyroid gland, in one word. You are not supposed to percuss over the thyroid gland. There is no expected clinical examination to percuss on a thyroid gland. Okay. Percussion on the sternal area is expected. Only thing is to auscultations to thyroid gland for the evidence of the brew is required. Doing a percussion note over a thyroid gland is not at all expected. You are not going to get any information out of it. It is not mentioned in your clinical examination.
You have already answered this, but the purpose of auscultation is only seeing the bruise. Second one is
Bruise.
tracheal position.
Yes.
Is your examination finished or you want to tell something more? After the eye
On the
signs?
system. Eye signs were absent, sir, in this patient. In this patient, sir, there is absence, sir.
Okay. Go to the next one.
And only the systemic examinations. The cardiovascular system, there's S1, S2 present, no murmurs, no ectopic beats were noted. Central nervous system, GCS were E4, V5, M6, higher functions intact, no focal neurological defect, no neurological defect, and the respiratory system bilateral ear entry present equal, no vesicular or no added sound noted. The musculoskeletal system, the back and the spine appears to be not normal, no bony tenderness, no muscle weakness also noted.
So what are the various CNS abnormalities you have to examine in a patient of a thyroid?
Any mental retardations, psychiatric disorders.
Adult thyroid. What are the things you are going to examine? No, you already mentioned, no, everything is normal in the CNS. So what are the things you examine to say it is normal? Right, starting from your tremor. What are the things you look into that?
Any fine tremors present or not, sir, in the...
How do you demonstrate that?
First, you have to start with the look of the patient. How is sitting in a bed? Whether she is restless, whether she is quiet, whether she is anxious. First, you have to look at the patient look. Okay. Then you have to look for the fine tremors or coarse tremors.
What tremor you get? Fine or coarse?
Fine, sir.
What is fine tremor?
Sir, if you tell the patient to move the leave the tongue for 30 seconds, there will be small flickering.
You are going to examine the tremor in the tongue.
And the hands also, in the hands, sir.
So what do you look
Straight.
at?
We will make the patient, tell the patient to make their hands straight.
So how will you say it is a fine tremor, not a cold tremor? Is it a physiological tremor or
Sir, only the finger flickering movement of the fingers, sir.
finger flickering movements? So fine and coarse depends upon the amplitude and the frequency. The higher the amplitude, it is going to become a cold tremor. The lesser the amplitude, you are going to get a fine tremor. It is just an exaggeration of the physiological tremor due to sympathetic overactivity. Like that, what you have in anxiety, tension, you get a tremor. Same physiological tremor is exaggerated in the thyroid.
So how do you examine that? The fine tremors, how will you examine?
Tell the patient to make their hands straight. Then we will tell them to hold for outstretch the hand and tell the patient to hold for some time. And there is any tremor, the patient cannot hold on a fixed. Patient cannot hold in a
We have to demonstrate the fine
for a
tremor.
fixed amount of time. There will be fine tremors over the hands.
That is for the flapping tremor.
And place a paper over those hands, sir.
So you have to put a paper, no? Now,
Yes, sir.
what precaution you have to take when you are putting the paper on the hand?
No AC only.
You should examine the patient in the air-conditioned room, not with a fan.
Yes.
Why fan, Abhijit? Why no? Why there
Yes,
should
sir.
not be any fan?
Sorry, sir.
Why there should not be fan in the examination hall?
Well, it will not keep the paper in the place of the
Ah,
hand.
it will fly up, no? Because of that's why. Again, when you are mentioning about this, you have to aware about this.
Okay,
I knew that Khanna sir is going to ask the same question.
What are the other things you are going to examine? Any motor system?
Myo reflexes.
Okay, you will look for the reflexes. Yes.
Tendon reflexes.
Any muscle weakness?
Peripheral calf muscle weakness may be present, sir.
Calf muscle. No, there's a typical of
proximal muscle,
right.
sir.
Proximal myopathy, no? So how do you demonstrate that? Proximal myopathy?
So we'll tell the patient to while in the sitting position, we'll tell the patient to stand up. The patient will feel difficult in standing up, sir.
You make the patient squat. Okay, then ask him to get up. He won't be able to get up.
Yes.
Okay.
So according to you, there are no toxic signs and no eye signs, and then there is a solitary swelling in the right lobe of the thyroid. No brew heard, no tenderness, and then what other any other swellings apart from that you have not mentioned about that in examination?
You have to separately mention about the regional group of lymph nodes.
Regional group. So I have not mentioned
So
about the
in the general examination, we have told there is any enlargement of the lymph.
In addition to that,
no.
specifically.
General examination you have to mention, but in relation to thyroid, you have to mention that. I will mention it at the last when you completing the examination of the thyroid swelling.
Okay. There are any enlargements on the glands.
Which
Where
group
you
of
look for?
node you will look for?
Sir?
Which group of lymph node you will be bothered? You will look for?
Level 6 Delphin node, sir. And 2, 3, 4 also, sir. And a posterior level 5. From lymph node group 1 to lymph node group 6, we have to examine, sir.
Why not 1A, 1B?
Submental and the submandibular group.
Are they enlarged in relation to the thyroid swelling?
No, sir.
Is there any possibility there could be still enlarged in relation to the thyroid?
Metastasis, sir.
Is there any possibility of metastasis to the submental and submandibular group of lymph nodes in relation to the thyroid swellings? Generally, they are not. Okay, I agree. Could there be still
Generally, it's not,
possibility?
sir. Medullary thyroid carcinoma, it can be present, sir.
No.
Level 1?
When the lymph nodes are enlarged, it signifies only a carcinoma. It will not signify the medullary carcinoma. Depending
Yes,
upon the level of involvement of lymph nodes, you are not making a diagnosis of a histological diagnosis.
Yes, sir. No. Only we can say that it's a carcinoma.
Only you can put
Maybe
it as
carcinoma.
because of the because of the lymph nodes are enlarged in relation to the draining lymph nodes of the thyroid. Only thing you can mention that it could be carcinoma. Level 1 and level 1A and 1B, they are not generally not draining group of lymph nodes. If there are a bulky metastatic lymph nodes in the lower group, there could be retrograde flow because of the extensive metastasis. There could be possibility of a retrograde spread. In those cases, the only level 1A and 1B can be involved. Generally, they are not involved. I expected this answer from you.
How many levels of lymph nodes are there in the cervical?
Right?
How many levels are there in the cervical nodes?
7, sir.
7. So in thyroid, which are the nodes which are involved?
In right, I didn't get the question, sir.
Which group of the lymph nodes are enlarged in a case of a thyroid swelling, thyroid cancer?
Most commonly 6, sir.
Okay. Then?
Level 2, 3, 4.
Yes, continue. Correct.
Usually 3 and 4 first. Then? Can the 7 be enlarged in the thyroid or not?
Sir?
Can the level 7 be involved in thyroid or not?
It can be involved, sir.
What is level 7?
Sternal regions.
What is the anatomical location for the level 7?
Suprasternal, sir.
You have mentioned mediastinum.
Level 4.
About the mediastinum. Should mention about the mediastinum. What is level 6?
Sternal and in the central region, sir.
Level 6.
Central region, sir. Level 6.
Central region.
Central in the suprasternal notch in the region, sir.
Is there any level group of lymph nodes in the suprasternal notch?
You must know the boundaries then. Central neck node dissection. That you are talking about central neck node dissection.
No, boundaries, I don't have any ideas about boundaries.
The respiratory system you have put as a no evidence of pleural effusion. Any particular reason you look for a pleural effusion? You have obviously come to the conclusion this is a thyroid, no node, it is a benign condition. Now, why you are spending time to look for a pleural effusion?
So in the
it is not a generalized.
So no need.
You are the others you are coming across. You just focus your case. You are almost saying it is a benign condition, and then again putting on an evidence of pleural effusion. All that is not necessarily we do for an examination routinely. When the breath sound is normal, will you do for a pleural effusion?
No, sir.
Okay.
You put the bony tenderness. If you find a bony tenderness in a carcinoma thyroid, which is the type of the carcinoma thyroid?
Follicular carcinoma, sir.
Follicular carcinoma. Good.
Which are the bony area? Which are the bony area commonly involved?
Sir?
It's a flat bone.
Which are the bony area?
Thoracic vertebra, sir.
Vertebra.
Vertebra is the commonest.
In the thyroid follicular carcinoma, where will be the secondaries commonly?
Common.
Most commonly, it is the bone, sir.
Bone, not the most common. Okay, most common.
Which bones are more common?
It is relatively a flat bone.
Flat bone.
You are putting your hand.
You're putting on your hand. Where is your hand now?
Yes.
Where are you putting your hand now?
So it is mainly in the scalp, then in the sternal region.
Skull bones, osteolytic skull bones.
Okay.
Generally, it is a flat bones. So most common is the skull bones. Then sternal bones, hilum, which are flat bones, then the vertebra. These are the bony metastases.
What are the other osteolytic lesions you have, secondaries? Carcinoma mainly producing
Could there
osteolytic.
be visceral metastasis?
Breast, sir.
Particular carcinoma?
Sir, breast also it is a
Yes,
osteolytic.
sir.
Breast is not mainly
agreed.
osteolytic. It is a most of mixture, but
Predominant.
more of osteolytic. Okay. What is the primarily osteolytic carcinoma? Other than follicular carcinoma. It's a renal cell carcinoma.
Renal, sir.
It is a osteoblastic carcinoma,
Prostatic carcinoma is osteoblastic.
but prostatic is more of a osteoblastic. Why it is called pulsatile secondaries? Thyroid produces pulsatile secondaries.
No idea, sir.
What pulsation it will get? If it is in the flat bone, when the cortex is lost, both internal and outer, you will see the pulsation from the brain itself. And more, all these pulsatile secondaries are due to the increased vascular endothelial growth factor, VGF. Okay. No pressure effects on the eyesight. Is it the pressure effects we see in the eyesight? You are interested in the last line, cystic in consistency with no pressure effects and pressure effects.
Sir, no pressure effects in over the
Okay,
veins, sir. Over the mainly the
I-
arteries, not over the eyesight, sir.
Good. That's good. Go ahead.
So what is your diagnosis?
The solitary thyroid nodule on the right side of the thyroid gland, sir.
Do you think that is the full diagnosis? Because that is
No,
just
sir,
an
after-
anatomical diagnosis you are giving. This nodule is there in the thyroid. So what are the causes of solitary thyroid nodule?
Sir, it can be colloidal nodule also, sir. It can be follicular adenoma.
So adenoma is the common.
Cyst.
Look, when you are saying solitary thyroid, it can be even a toxic nodule, can be also solitary.
Yes, sir.
So what is the metabolic status of the patient? Is a euthyroid or?
Euthyroid, sir.
But you said the pulse rate is 92.
Yes, sir.
So do you think still votes for the euthyroid? And why there is 92 you are getting in a euthyroid?
Sir, it's not tachycardia, sir. Because
Okay, maybe because seeing you, the patient might have got frightened or got anxiety. Fine, that you should
What
mention
is the
yes.
differential diagnosis of a solitary thyroid nodule? One, you said it is a colloid nodule, colloid goiter. Second, you said
yes, sir. Follicular adenoma, sir.
yes.
This can be papillary. Sorry, sir. It can be malignancy also, sir.
Yes, it can be carcinoma. Yes. What else?
Benign cyst.
Cyst. Yes. Thyroid abscess.
Abscess. Yes, sir.
So, what is the percentage which is by the colloid multinodular goiter? What is presenting as solitary thyroid nodule? Around 60% of the solitary thyroid nodules are the part of that. Okay. So when you are giving this provisional diagnosis as a solitary thyroid nodule, one thing you have to tell whether it is a euthyroid or whether it is a hyper or hypogeia. Okay. And also you have to tell in possibility that is it a case of a colloid goiter or it's a, you can say adenoma, or it may just a simple cyst may be there. You know, you are saying it's a cystic one is there. So it may be just a cyst.
Yes, sir.
What do you understand by thyroid incidentaloma? Thyroid incidentaloma.
Any incidental? No, sir. No idea, sir.
Incidentaloma? No idea? Okay. So what do you want to do for this case?
So we'll go for the FNSC and the ultrasonography of this patient for this patient.
Nodule of a multinodal goiter?
Sorry?
Can it be a dominant nodule of a multinodular goiter? Because you are not mentioned about the other lobe.
Suppose your ultrasound you are doing, can it become a multinodular goiter? What happened to the other lobe, left lobe?
So left lobe is normal.
Clinically.
There's no enlargement noted over the left node, sir.
Pyramidal
Left
lobe?
lobe, sir.
Pyramidal lobe?
Sir? Pyramidal lobe? No, sir. Only one in the right lobe, sir.
But the picture shows there's a left lobe is also little, not obviously. The left side also they are having seeing a swelling. This looks
No,
like
sir, I cannot. This one, sir, I cannot feel in that way, sir.
fine. It's okay.
Let me tell you about thyroid incidentaloma. Thyroid incidentaloma is a incidental finding, like when you're doing a ultrasound of the neck for, you know, what is the commonest cause of getting out the ultrasound of the Doppler of the neck? What is the commonest indication for that?
Any enlargement,
When
sir?
you're looking for the carotids.
Carotids.
Yeah. So if the patient is having like any stroke is there or any history of any, you know, problem is there, you are carrying out that and you find at that time that there is a nodule in the thyroid is there, but this nodule should be less than 1 centimeter in size. Like in case of adrenal, what is the size of the incidentaloma when you say it is an incidentaloma which is not functioning? What is the size there?
Less than 2 centimeters.
No, 4 centimeters.
4 centimeters.
In the adrenal, it is 4 centimeters. In the thyroid, it is 1 centimeter. If it is less than 1 centimeter, usually you do not require to carry out any further investigation for that. If it is just the incidental. But if it is more than that, then you have to investigate that particular nodule. Okay. So what are you going to do for this patient?
So we'll go for the ultrasound and the FNAC for this patient.
What is the quadruple assessment for the thyroid?
Thyroid function test.
Yes.
Biopsy, FNAC, and the ultrasonography examinations.
So clinical examination
and the clinical examination.
FNAC and the thyroid functions. That is a quadruple examination. Okay.
Yes.
So what are you going to do for this patient? Clinically, you're done. Then next, what you will do?
We'll, on the basis of the ultrasound and the FNAC report, we will proceed, sir. If the
you have to do the thyroid function test here.
Yes, sir. Thyroid function test
So
also, sir.
Thyroid function test, which one you will do? Where you think clinically it is thyroid, what you will do?
T3, T4, and free T4 and the serum TSH.
No, you have to given only one choice. That you have to carry out only one investigations where you are clinically not suspecting it is hyper or hypo. Which one you will do?
T3, sir.
No, you will do the TSH. Okay, you will do the TSH function for that. And if the TSH comes out abnormal, then you go for the other test. So if you have to do the one other test out of the like free T3, free T4, total T3, total T4, which one you will do? If you have to carry out just one test.
Then we'll go for VT3, sir.
Free T4. You will go for the free T4 for that. So for the screening purpose, TSH, and making a diagnosis, the free T4, if you have to just do one.
Yes.
Has the ultrasound been done in this patient?
Yes, sir. Ultrasound done, sir.
For carrying out the ultrasound of the thyroid, what was the frequency of the probe which was used?
5 to 30.
5 to 30.
Such a big variance. Have you ever seen a 30?
So low frequency probes only will be used, sir. Sorry.
Low or high?
High, sir.
When you do the abdominal ultrasound, you know which frequency is used?
Low frequencies in the abdominal ultrasound, sir, because
What is
the
that
deeper
low
structures.
frequency?
Huh?
What is the low
frequency?
Frequency or the low frequency?
Okay, it is 3.5 to 5 megahertz. Okay, 3.5 to 5 megahertz for the abdominal examination. For breast, thyroid, you use around 10 megahertz.
When will you say a sound as ultrasound?
So which cannot be audible.
What frequency?
Get at approximately 20 megahertz.
Yeah, you are right. 2 megahertz, not 20 megahertz. Okay.
2 megahertz.
And suppose you have set a T3, T4, TSH, where the T3, T4 is low and THS is normal. What are the possibility you think? T3,
Sir,
T4
T3,
low.
T4?
Low. Value is
T3,
low.
T4 low, sir.
And TSH is normal.
Euthyroid 6 syndrome.
Good, good. That is a euthyroid 6.
Okay, so ultrasound shows it is thyroid 4. What does that mean?
So thyroids, the classification which has been used.
And sir, we need to close this case with another 5 minutes, sir.
Okay, okay, right. So what are you going to do for this
In
patient?
the
Tell
T4
about
means
that.
it is suspicious of the malignancy.
Okay.
Suspicious of the malignancy.
Like FNAC you have done, it comes out to be a case of a follicular adenoma.
Yes, sir.
Right. So what are you going to do for this patient? Is the
If
thyroid
this
4
comes out to
lesion?
the, we'll go for total thyroidectomy, sir.
Why total thyroidectomy?
After the frozen, sir.
Why total thyroidectomy?
Because so it is highly malignant because of the malignant potential of this tumor.
So for all malignancy of the thyroid, you go for the total thyroidectomy?
No, sir.
Mm-hmm.
In the follicular case, in the medullary carcinoma.
No.
In those cases, we go for the
any criteria.
Highly recurrence. It's a very highly recurrent tumor. Recurrence is very high, sir.
For a papillary carcinoma, when will you do total thyroidectomy? When you are justified in doing a chemithyroidectomy in a papillary carcinoma.
Papillary carcinoma.
What is micropapillary carcinoma?
So if the size is less than 4 centimeter or there is no any lymphovascular invasions.
Less than 1 centimeter, you are definitely you will do the chemithyroidectomy. More than 4 centimeter, definitely total thyroidectomy.
Go for the total thyroidectomy.
1 to 4, you divide into low or high, depending. What are the scores with which you will categorize?
Yes, sir. AGES, AGES score, MSCIS score, sir. And AMES score, sir. Where the
you are awaiting the FNAC report in this case.
Yes, sir.
This.
Can you stop, Dr. Jagannath?
Yeah, yes. since we need to go for the next case,
That's right, yeah,
Abhijit, do you have any questions?
No, sir.
You want to ask any questions with related to your case presentation? If not, thank you, Abhijit. Thank you for participating. I think this is your first attempt, but we appreciate your efforts. Be relaxed, present in a fluent way. You will be all right. Thank you, and please
All the best.
take off your slides. Next presenter is ready.
Hello, very good evening, sir.
Yeah, Sugant, you can start presenting.
Very good evening, sir. I'm Dr. Sushant Babal from Cooper Hospital, Mumbai. My guide is Dr. Geeta Ghal, Professor Dr. Geeta Ghal, and my HOD is Professor Dr. Smriti Ghetla.
They are not seeing your slides. No?
Yes, sir. Just sharing my screen, sir. Yes.
Okay, go ahead.
Yes, sir. Is it visible, sir?
Yes, go ahead.
Yes, sir. Sir, today I'm presenting a case of lump in abdomen. So my patient is a 77-year-old male, Muslim male patient, Peer Muhammad, tailor by profession, and resident of Vasai, came with a complaint of fullness in upper abdomen since 20 days. Patient was apparently well 20 days ago. Then he noticed fullness in upper part of abdomen, which was not associated with pain. History of anorexia since 6 months. History of weight loss was given by patient since 6 months. History of passing black colored stools on and off was given by the patient. There was history of irregular and decreased bowel habits with passing of stools on alternate days. There was no history of fever, no history of nausea, vomiting, no history of hematemesis. There was no history of acidity, regurgitation, burning chest pain, and there was no history of abdominal fullness post-meal. There was no history of blood or mucus in the stool. No history of altered bowel habits, altered bladder habits. No history of any psychological disorder or habit of eating hairs, as told by the patient and relatives. No history of any pain in epigastric region, radiation of the pain to the back. There was no history of alcohol consumption, smoking, or any drug addiction. No history of jaundice, itching, and clay-colored stools. No history of passing worms in stool. No history of hematuria and trauma to abdomen. History of patient is non-case of diabetes mellitus since 10 years, but is on irregular medication. History of pulmonary cox 2 years ago and taken AKT for 9 months as told by the patient. There was no history of hypertension, COPD, ischemic heart disease. History of previous inguinal hernia repair surgery. Right inguinal hernia was repaired 40 years ago and left 13 years ago. No history of previous similar complaint and no history of any non-drug allergy. Regarding personal and family history, patient is married with mixed diet. No similar history of lump in abdomen in family noted. No significant contributory history noted. Yes.
Did you elicit about periodicity?
Periodicity of the lump, sir?
Periodicity of gastric complaints.
Yes, sir. A patient, sir, gastric complaints, he's having the irregular bowel habits of passing stools on alternate days. And history of, sir, passing black colored stools irregularly since last 3 months.
If it is going to be hypertrophic pylori stenosis, will you not ask about
yes, sir,
periodicity? That's what I want to tell you. Should you not ask about it? No, you have to mention about it.
Yes, sir.
You want to rule out benign causes.
Yes.
Any history of contact with animals?
There is no history of contact with the dog and there is no pet history given by the patient, sir.
The Gerald, sir, take over, sir.
No, it was only 20 days history, yeah?
Yes, sir. Patient noted the lump, the fullness in upper abdomen 20 days ago, sir.
Okay. As it has been also pointed out, we do not expect the candidate to disclose the name of the patient and the religion.
Yes.
It's not good when we are presenting. So you need to avoid that.
Okay.
So what is the main complaint of the patient?
Patient came with the chief complaint of abdominal fullness in upper abdomen, sir, since last 20 days.
Any loss satiety was there? Early satiety was there?
The history of anorexia was there, sir. History of
Anorexia is entirely different from satiety.
No, sir.
You are not mentioned about early satiety here.
Yes,
If the patient has any symptoms of early satiety.
no, sir.
What does early satiety mean?
Early satiety is after consumption of food, the patient will feel fullness.
That is
At yes, sir. The
after consumption, he will feel the fullness. So what will he do? So that is one of the you have taken long history with again repeatedly saying nausea, vomiting once, then hematemesis again second. A patient who has no nausea and vomiting, he cannot have hematemesis. You are asking it again. And one end you are saying the no urinary abnormality, then again you are asking the history of hematuria. So all these should be avoided in the postgraduate presentation. You should go in an orderly way. Okay? One system you are asking one question means that should be the questions you are talking.
yes, sir.
And here
Sure,
the
sir.
main symptoms you are not asking with related to the upper GI problems. Within the 20 days, how will you explain an anorexia? What is anorexia?
Anorexia, sir. Loss of appetite, sir.
Loss of appetite. So this patient had a loss of appetite. So within 20 days, it's all, see, when you are presenting a case, now you are going to present an acute case. If it is only your history is right, within 20 days. There we will not be concentrating on the weight loss and here you are saying the passing black colored stool.
Yes, sir.
And later in the history it says there is no blood in the stool.
He's passing black colored stool, sir. There is no fresh blood in the stool, sir.
Why is it a black color stool?
Sir, is due to sir melena, due to most likely due to upper GI bleed, sir.
So what is upper GI?
Upper GI, sir, proximal to the ligament of threads. Yes, sir.
Where is it?
Jailal, can I ask questions? One or two questions.
Yeah, please, sir, go ahead.
Dr. Sushant, not to avoid all this confusion and getting into trouble, see, you should know that patient is 77-year-old.
Yes, sir.
He might have come for the 20 days duration of the lump, but you have written here anorexia and weight loss 6 months.
Yes, sir.
So that would have solved your problem. What you would have presented as, tell me. See, you don't have to take that patient has come with the swelling in the abdomen, first complaint. Not like that. It is not like that. You understand?
Yes, sir.
Patient, he may not know. So you should have, then all these questions would not have come. Loss of appetite, loss of weight, 6 months duration, upper abdominal, whatever that mass, 20 days duration. Simple.
Yes,
You should have gone like that. So that one by one you start. So what are the possibilities you would like to consider when these 3 statements are there? 77-year gentleman with loss of weight, appetite loss, 6 months, and epigastric mass. Just tell me quickly 2, 3 possibilities and let us proceed from there.
Sir, considering epigastric mass with loss of weight and since last 6 months, I would like to go with the, sir, there could be some gastric mass, gastric malignant mass, sir.
So don't have to say some gastric. You can even justify it straight away, telling what is more common things are always common. Uncommon things are uncommon. Rare things are rare. Okay.
Yes.
You don't try to say just lymphoma. All that is later. That is not confuse the matter. So you would like to think. You are absolutely right. If you say gastric malignancy, possibility. It is not that you are good. That is why these questions will come. Early satiety. All that thing. What is early satiety means? Early satiety means what? You can't take his, whatever food. Suppose you might have 2 chapati, whatever rice.
The amount of sir food taken by patient has significantly decreased, sir.
So that is So that also is one of the important reasons here. Early satiety is there. So that is what you also should have carefully asked that question. How much is he able to eat before?
Yes.
You understand? No vomiting. Okay, I won't ask details about all this reasoning and all that thing. Weight loss is there. So you are thinking in terms of stomach is one possibility. So quickly, not to waste the time. Suppose I say it is pancreatic malignancy. Now tell me. This is how you should ask the leading questions now.
Sir, in pancreatic malignancy,
Put
patient.
the next slide. Next slide you put.
Yes, sir.
It is there. See, you have written all this noise, fever, and last altered bowel habits and all. See, that should have come later. You understand, no? Loss of appetite, loss of weight, epigastric mass. So, yes, acidity, regurgitation, burning, all that is okay, all that is over. So, yes, what is the question I asked you? I am giving you, say, carcinoma, body of the pancreas.
So the black color stool is also here, blood. So don't put as a no history of blood and mucus in stool.
Yes, sir.
Okay.
So, history and all this, so you are not answered my question. So what is the answer is simple, no history of any backache, but it is not mandatory. When you expect a large mass from pancreas, epigastric mass, so you are trying to rule out one by one, stomach, pancreas. Why did you ask that question, no history of fever?
In case of, sir,
please talk about your patient, epigastric
yes, sir.
mass.
In case of amoebic abscess, sir.
See,
yeah, it's more on the left side.
So I wanted you to say liver tumors. What liver tumors? What liver tumors? See, this is how the examiners will ask you when you ask no history of fever, you are telling amoebic liver abscess. Do you think you will have this kind of a picture? 6 months loss of appetite, loss of weight. No. So hepatocellular carcinoma. No, it's very well known.
How it produce fever?
Yes.
Hepatocellular carcinoma, will it produce fever? Due to paraneoplastic syndrome. It is also part of it, IL-6 and secreting.
Tropical countries, it is confused as anemic, somebody puts it, need also. See, every question when you ask, no history of fever, you should have back of the mind, okay, I'm considering liver, okay, liver tumors. Pulmonary metastasis. You have to ask later for that also. History of, to find out the clue. Stomach, pancreas. So like that, if you go on asking, then you will be drawn. Okay, sir, please go ahead. Sir.
Yeah, next slide. So again, you are coming for passing worms in the stool. No history of passing worms in the stool. So please try to avoid when a PG is talking about the stool, everything on related to the stool, ask in a one go. Don't try to put all the things in a separately. So you what is the possibility you thought it's a gastric carcinoma? Is there is only the pain is only for 20 days?
There is no history
and you
of
are
pain
not
during the
described,
patient, sir.
It's a painless tumor totally.
Yes, sir.
So do you expect this to be a patient is bleeding? You said blood is there in the stomach, but no pain, no other symptoms related to the gastric.
Yes, sir. The gastric malignancies, sir, they become painful in very later stage with the.
They become painful in the later stage.
Yes, sir. When there is retroperitoneal extension of the tumors, or yes, sir.
Absolutely not. But that's all for the pancreas when you are talking of retroperitoneal tumor. Okay, your case. And anywhere. Okay, what is the status of the patient now? With the history, what is the diagnosis you are making?
Sir, from above history, sir, I am suspecting gastric mass, or it could be, sir, sir, hepatic mass of the left lobe. Sir.
So, as Sir has discussed, you are thinking it's a hepatocellular carcinoma. Do you think a possibility of lymphoma because you are asked for the history of fever?
Yes, sir, it could be there, sir.
What could it be? What lymphoma? If you think as lymphoma, what is the lymphoma you are thinking? You have two common lymphomas, Hodgkin's and non-Hodgkin's. Which one you think in the stomach?
Non-Hodgkin lymphoma.
So what is the primary gastric lymphoma?
Non-Hodgkin.
No, it is entirely different. Primary gastric lymphoma is entirely different from a non-Hodgkin's lymphoma.
Okay, sir.
You know that Dawson criteria for the primary gastric lymphoma, the classification, staging, entirely different. So we are not going to talk about the lymphoma here. So tentatively, we'll keep these two diagnoses as a possibility and proceed with that. Go ahead for the clinical examination.
General examination, sir. Patient was examined in well-lit room, in lying and standing positions from head to toe, with well exposed from nipple to knee. Patient is conscious, well oriented to time, place, and person. Averagely built and nourished. Patient with normal pulse rate, normal BP. Pallor was present, sir. Icterus was absent. There was no clubbing, no generalized lymphadenopathy. Leading to the systemic examination, the CVS examination, SN2 was present.
Anything else you noted in the general examination, though?
General examination.
If you see the abdomen, the picture which you are showing.
Yes, sir.
Any cutaneous markers are there? What are the cutaneous markers you will think in terms of carcinoma stomach or any visceral malignancy?
Sir, I am not able to appreciate.
Okay, you do not know. Lesser prolactin, acanthosis, nigricans.
No, sir.
Right forms. Okay. So you must think there is a lot of cutaneous nodules or papillomatosis lesions were there seen in the abdomen.
Okay, sir.
Okay. Good. And you are not talking, you are suspecting a malignancy, but you are not talked about his nutrition, his hydration, and we are not talked about his Karnofsky score or any score which you want to do.
I should do, sir, Karnofsky score for this patient.
Or ECOG score. One of the scores would have been there. If the patient is not taking food, there is a lot of patient has, whether the hydration of the patient.
Patient
So
is
not,
well built, nourished, and sir, there is.
What do you mean by built?
Yes, sir. Built is.
Do you think carcinoma stomach will alter the build?
No, sir.
No. So, but it will be affected, nutrition will be affected.
Yes, sir.
So you are not mentioning about the nutritional status of the patient. And you are not mentioning about the BMI of the patient. So as a postgraduate, these things are mandatorily required when you are talking about, especially in the case of a malignancy.
Yes, sir.
Okay, go ahead, next.
In systemic examination, the cardiovascular systems, central nervous system, respiratory system, all were normal. Per abdomen, there was soft, non-tender, and bowel sounds were present, sir.
I do not know that. Whether Chennai sir is there, will you follow just the general examination? After that, you go for a systemic examination and talk about per abdominal examination also there, or you go to the after the general examination, go for the examination of the particular part, and then come for the systemic examination.
Always loco-regional, no? This we have told several times, no?
Several times.
Always, huh? Always. So don't say, come to the abdomen first. Okay.
Yes, yes.
After the general examination, we will appreciate if you say dilated veins in the flanks, not just capital say. We'll appreciate if you say systemic nodule, if any nodule is seen in the umbilicus. You say just medial edema, you make a statement. All that, importance is there in a abdominal mass. Okay.
Yes, sir.
After that, you come to the abdominal examination. Then systemic examination later.
Right. And here also, don't write as a local examination because that the word is not going to give you any answer. So you must say examination of abdomen.
Yes,
whatever region you are going to see, if it is examination of the breast or examination of the neck, and so what you are going to examine, that region you should write, not just making as a local examination. So examination of the abdomen.
Yes. Examination of the abdomen, sir. On inspection, there was fullness in the epigastric region with flat abdomen. There was no generalized distension. Skin over abdomen was normal with no dilated veins or sinuses. A bulge in epigastric region measuring around 18 to 6 centimeter, approximately, moving with respiration.
Call it a bulge. You don't call it a bulge in the abdomen.
Yes.
Use proper word. In the beginning also, I wrongly mentioned as a hypertrophic pylorus. That's not the one I wanted to tell you. I wanted to tell you the cicatrized duodenal ulcer. In that case, you will ask about the periodicity. You don't mention it as bulge. You say it's a lump or mass. You call it mass or lump.
A mass in epigastric region, measuring about 18 to 6 centimeter, moving with respiration, and diminished on the raising the neck. Umbilicus is normal in midline position and inverted. No visible peristalsis or pulsations noted over the lump. Previous surgery healed scars noted in the bilateral inguinal region. There is no scrotal swelling. No bulge in the left supraclavicular region, inguinal region, or axillary region. There is no spinal deformity. Yes, sir.
Shushan, if you see the same, the first line starts with the fullness in epigastrium.
Yes,
and the third, fourth line, you are saying there is a lump in the epigastrium.
Yes, sir.
Why that is variation coming? So if you see, you can start with the mass or the shape of the abdomen, you can start with that.
Yes, sir.
Okay. And now you are suddenly you are bringing the hernia scar here, which you have never mentioned in the history also. Past history, not mentioned. But all of a sudden in examination, you are bringing there is a hernia scar here. Go ahead.
On palpation, sir, the inspective findings were confirmed. The patient was afebrile. A single intra-abdominal 10 into 10 centimeter oval-shaped lump in epigastric region, firm to hard in consistency, non-tender, with smooth surface and well-defined margins in lower half, and the margins in upper half not palpated.
Prashant, what is afebrile in abdominal examination?
The core body temperature.
First line is afebrile.
Yes, sir.
In the abdominal examination, what is that?
If you are said in the general examination, it's okay. But here, the local examination of abdomen.
So what do we say if there is a increased temperature is there?
There is no local increased temperature, sir.
No local rise of temperature. Yes. If you have to describe that, do not say afebrile. If you're having the fever.
Yes.
Okay, so you have to tell about that. There is no localized tenderness is there and there is no localized increase in the temperature is there. Okay.
Yes, sir.
Yeah.
The lump is not freely mobile. Fingers could not be inserted between the lump and the costal margins. Lump disappeared with the head and leg raising.
Disappeared?
Yes, sir.
The total lump, 10 into 10 centimeter mass disappeared on head raising.
Yes, sir.
It must be a miracle.
Becomes less prominent. The answer would have been less prominent on leg raising test. How it can be 8 into 10 centimeter disappears on a, becomes less prominent.
It becomes less prominent.
In the previous case only, Ishwar Shah has said 3 into 4 cannot be spherical. Similarly, 10 into 10 cannot be oval. So you must, every small points you are adding, you must be very careful. Okay.
Yes, sir. The liver, spleen, and kidney are not palpable, sir. No other lump palpated in the abdomen. No expansile impulses over the hernia site on cuffing. Both testes in the scrotum and the normal in size and consistency. The left supraclavicular lymph nodes are not palpable. No relar agal tenderness and paraspinal spasm or spinal deformity noted. On per rectal examination, there was normal anal tone, no mass palpated, there was no melena, and gloved finger stand with stool, sir.
Neck.
You can feel the kidney. Prashant, you said that.
On percussion, sir.
Go to the last slide.
Yes, sir.
Liver, spleen, kidney not palpable.
So liver and spleen are not palpable, sir, and kidney.
So you finished under palpation, including rectal examination, everything over, and then you came back to percussion, is it? See, Sushant, you can't do this. No, you are a postgraduate. See, correct? No, if I am not wrong. Next slide is percussion, correct?
Yes, sir.
How will you go about in the normal schema of the presentation? Like, how will you go normally? Palpation, you started with all this mass first, correct?
Yes, sir.
After the mass, what will you do? Liver and spleen. If let us say this is not a, because why we talk about liver and spleen? When it is enlarged only, obviously, because they are the common abdominal masses which which are enlarged and which are easily palpable. That is the reason. You understand? No, we don't say mesenteric lymph nodes are not palpable, paralytic nodes are not. Generally, in the examination point of view, also they are involved in systemic diseases, specifically to look at. So we generally say, and in females, in particular premenopausal. Will you say anything else? In a females, particularly in females.
Regarding, sir?
In the abdominal masses, after you describe that whatever epigastric mass,
yes, sir.
better to say, okay, hepatosplenomegaly, this is not that I'm particular, but it is not palpable. Then I said in females, premenopausal, and particularly you have to say any lower abdominal masses.
Sir, periumbilical group of lymph nodes.
Periumbilical group of lymph nodes.
You are coming back to what I want to ask. Purkinje tumors. You understand whether it's a breast or a stomach, whatever it is. So once you have done all these things, sir, then you do the percussion, auscultation. Groin should be separately checked in the standing position. You can't make the patient lie down and say he does not have a hernia. I think you know that.
Yes, sir.
Similarly, give a specific examination of genitalia when I say men, especially for the testis. It should come only after that.
Yes, sir.
Rectal examination, and then you have gone back to the percussion. I think you need to correct that. Okay, please. Yes, sir.
And certain findings you must have in the inspection, then only you are going to examine. You said inspection, there is a hernial scar. You never talked about the calf impulse there. Suddenly you are going to come for a expansile calf impulse. When you are not having a calf impulse, then why should you go for whether it's expansile or transmitted? Similarly, inspection, you could have seen the spinal deformity.
Yes, sir.
But the palpation, you are coming and saying there is no spinal deformity. So this mixing should be there. Spine, scrotum, scalp, all should be separately, supraclavicular node. All should be separate entity. You are going to bring it separately after you are finishing out this examination.
Yes, sir.
Okay. So this mass you are seeing, but again, sir, Tanai sir, you must say what is, whether he said the mass is disappeared on head rising. How will you accept that, sir?
Because we can't really, that picture, in picture itself, was it very prominent? Was it because what he is telling is don't say disappear, you just say that yeah, on see, he's actually emaciated. See, you can see that, no ribs. See, can you see
even the emaciated umbilicus is not in a normal. It is
see carefully here, probably. Look at this. There could be a small nodule. We don't know. We have no. And whatever you have written like this, and there's some more line is here also above. I don't know. So what he meant probably is that mass moves with the respiration and inspection. And I would have described this as probably vague fullness is seen in the epigastric, better word, and moves with respiration, and then on head raising test, mass becomes less prominent. Or that's better, I think, rather than that has been clarified.
Okay, go ahead with the percussion, Sushant.
Yes, So on percussion over the lump, the dull note over the lump continues with the liver dullness, with the upper border of liver lying in the 6th intercostal space. The splenic dullness is normal, sir. There is no clinical evidence of free fluid in abdomen, sir.
Where do you look for the splenic dullness?
Pardon, sir?
Where did you look for the splenic dullness?
Sir, in the left, just below the, sir, left.
No, where do you get the splenic dullness? Where it starts, where it ends, and what is the? Is it a common to find the splenic dullness when you have spleen is normal? You said already in a palpation, spleen is not palpable.
Yes, sir.
And how you are going to make out a splenic dullness and make out the boundaries of the spleen? What is the trough space? You know, what are the other space you would do for the dullness? Percussion. Trough space?
No, sir.
No. It's a crescentic space in the upper end, where on the bounded by the left lobe of the liver, lower part of the lung, and the costal margin. So if you are percussing at that region, normally it is resonant. But in the mass, it will be dull.
Yes, sir.
In the fundal mass or thing. So that is more important than going for a splenic dullness you are going to talk.
Yes, sir.
And fluid collection, what test you? No clinical evidence of free fluid. What are the tests you have done?
Sir, shifting dullness.
How will you do shifting dullness?
Shifting dullness, sir.
How will you do?
Sir, patient is lied in supine position. Then percussion is done starting from the midline, sir, umbilical region, and going towards laterally. And
so you start at umbilical region, going to the lateral side.
Initially starting from midline, yes, sir, and going towards laterally.
Right. Why can't you mention that from the epigastrium? You have to start percussing from the epigastrium.
Epigastrium, not from the umbilicus.
Not from the umbilicus.
There can be localized ascites in the upper abdomen.
Okay, sir.
So because why we are asking this question means that's where the PGs are making mistakes. You are only taking it granted that you know, and you are not doing that. You are not spending time in doing a splenic dullness or a shifting dullness. Just presenting spleen is not there. So when we are routinely doing, definitely you will be able to tell that very easily in the examination. So examination of the case is more important because PG exam is going to happen with not on online. It is going to be there. The examiner is going to see the case.
Yes.
Okay.
You may be asked to demonstrate how you done the shifting dullness.
And auscultation, you had a normal peristalsis is here. What is that?
Sir, bowel peristaltic sounds were audible, sir.
So you had a bowel sound is here.
Yes, sir.
How much is the bowel sound? How much was the bowel sound you had?
Sir, bowel peristaltic sounds, sir, it occurs around 20 seconds.
20 seconds. No. It's like a heart rate you are saying 72 per minute, and you will have something for the per minute, no? Why did you auscultate it for the bowel sound?
In this case, auscultation of the bowel sounds is more important, or auscultation of some other sounds is more important when you describe the mass in the epigastrium.
The auscultation of the mass is important, sir.
What do you look for?
The
mass per abdomen case, bowel sounds doesn't have any meaning unless you are suspecting a case of an obstruction.
Yes.
When you present it to the mass per abdomen, the need for auscultation is for some other reasons, not to look for the bowel sounds.
Also.
Sir, any aneurysm?
If you describe the pulsatile mass, okay, definitely we expect that.
Yes, sir.
Describe it as a non-pulsatile mass.
Yes, sir.
So he has looked for the bruit there. So if you are hearing a bruit at that region, where could have been the problem?
In a non-expansile mass. The highly vascular hepatoma sometimes will have a
bruise. Yes, sir.
Okay, what? Go ahead with what is your diagnosis now?
Did you look for the visual peristalsis here?
There were no peristaltic movements noted, sir. Yes, sir.
How did you know that there is no visual peristalsis? What are the various ways to initiate the gastric peristalsis?
Yes, sir. Patient is given to see the
You can just tap over the abdominal wall.
Yes, sir.
Sometimes that can initiate the visual peristalsis.
Yes, sir.
Sometimes you can put some type of the solutions there which can initiate the peristalsis, or you can give the patient the liquid to drink and you can see for that.
Yes, sir.
Did you look for the succussion splash here?
No, sir.
In a suspected case of gastric carcinoma and with a lump which is there in the epigastrium there, would you like to auscultate for that?
Yes, sir.
How will you do that?
Sir, patient being empty stomach, we will look for splashing.
Empty stomach.
The stomach is empty, there will not be succussion.
The patient should not have taken fluid for 2 to 3 hours before, before you attempt for looking for the succussion splash.
Yes.
Okay, so you put a stethoscope over the epigastrium, shake the patient, and then you can hear that. What are the other places where you can hear the succussion splash apart from this dilated stomach? Anything in the chest?
No, sir, I don't remember.
Hydropneumothorax?
Yes.
Okay. Right.
So, how you are going to proceed?
Hello.
This 77-year-old male, sir, coming to diagnosis, sir, this 77-year-old male with the intra-abdominal lump in epigastric region, my differential diagnosis goes to, sir.
Diagnosis.
Yes, sir. Diagnosis goes to, sir, liver mass, sir. This more likely left lobe liver mass, sir.
So the first thing is the liver mass. And you are putting the same differential diagnosis and another brain condition. Amoebic liver abscess. So do you want to bring one extreme malignancy and another is a benign?
Benign disease.
Is there any pointing to say it is amoebic liver abscess?
Is it more common for the left lobe?
Absolutely painless one, you said.
Yes, sir.
You said patient has a melena. So why do you think amoebic liver abscess at all here?
Yes. Sir, I was suspecting, sir, left lobe of liver could be involved.
Which is the commonest lobe involved in the amoebic liver abscess?
Most common, sir, lobe, segment number 7, sir.
Segment 7.
Is it right lobe or left lobe?
It's rightmost, sir.
Then
Okay.
more common in the right lobe, more in the posterior superior. In such cases, liver will be enlarged more towards the cranial area. It is very uncommon to be palpated at the lower down. There will be intercostal tenderness, patient running with a fever, the signs of toxicity. All these things are there. So you can't have extreme diagnosis. One is putting as a hepatocellular carcinoma, another is amoebic liver abscess. Okay.
Yes, sir.
You could have described the other liver masses if you want to put it as a differential diagnosis. So definitely not an amoebic liver abscess.
And okay, thinking it's, why do you think it's the first priority is the liver mass? What pointing made you to think that it is a liver mass than a gastric mass?
First, sir, the dullness of the mass is continuous with the liver. And
first, your shape you said is a oval mass or 10 into 10 centimeter mass. It's a rounded mass.
Yes, sir.
Normally in the liver mass will not be of that kind of category. So you have the liver margin, liver palpable, where the total liver, right lobe totally, the liver is not palpable here.
Liver was not palpable, sir.
Palpable. So but still you want to put it as a liver mass. Any other clinical finding to think it is a liver mass?
Yes, sir. The superior margins of the mass were not palpable, not distinguished, sir.
In the stomach, you can feel always the superior margin?
Not always, sir.
Surface, he said it is smooth, and he has not mentioned about the borders of the lower border. Whether it is sharp or rounded or irregular.
Is
no, he is not thinking in terms of liver at all. He's in the findings is never said.
Malignant liver, no.
Yes,
First
yes.
diagnosis, he has said malignant liver. Some points must be in favor of that first diagnosis, no?
Yes, it is a hard.
Any clinical finding you get in. Okay, it is a uniformly hard.
Yes, sir. It is hard mass, which is moving with respiration, and so the upper margins of the mass are not distinguished. So and its dullness it continues with liver.
It is the liver dullness.
But
These are the reasons to describe that it is a liver mass. Okay.
Intrinsic mobility is restricted, you said.
Yeah, it is not mobile, sir.
Oh, so you expect a liver mass coming from the left lobe of the liver will be immobile. Okay, and why you are not thinking in terms of a gist or any other lesion from the stomach? If you are thinking that it is a dull. Okay, go ahead. How you are going to proceed? Running short of time.
For further evaluation after clinical evaluation, I would like to go with, sir, basic blood investigations. Those were done, sir, and patient with CBC of 7.6.
Again, many times that means you have not seen any of our previous PG discussions, because all the professors will think when there is a malignancy you are suspecting, confirmation of that is the first priority.
Okay, sir.
Not your blood test. So TCDC is not coming. This only comes when you are going to do any therapeutic intervention. So first, your confirmation of your diagnosis.
For confirmation, sir, I would like to go for radiological investigation first with USG.
So have you done a USG for this patient?
Yes, sir. USG was there was an ill-defined hyperechoic mass lesion measuring around 13 into 12 centimeter in the epigastric region, and it was extending into the left lobe of liver with hypoechoic area, sir.
So that is why you have put as a liver as a first. The examination that will be a difficulty. So we don't come CT and then discuss. No? So I mean, it's better if you have this put as a gastric mass as a first, and then you have put as a liver. It would have been much better.
Yes, sir.
No problem. You go ahead. Okay.
After doing USG, sir, I went with contrast CT, triple phase contrast CT of the abdomen. And
what is the need to do CT in this case? In the ultrasound is already shown that there is a mass lesion there.
Yes, sir. To vascular involvement of the mass lesion, sir.
The proper answer is to stage the liver disease, and as far as for the management purposes. So for these two reasons, you need to go for a contrast enhanced triple CCT has to be done in this case.
Why do you want to use the contrast enhanced? What are you going to get by the contrast enhanced?
Sir,
so how will you differentiate a primary tumor or a secondary tumor by doing a CT?
Whether it is a primary or a metastatic lesion, sir.
Yes. How do you make it out in the CT?
How contrast will help you to decide?
So which will secondaries will when it will take up, and the primary tumor when the enhancement will be there.
The primary tumors will enhance in the early arterial phase, sir.
Okay, why?
So
there will be
more vascular.
Is vascularity.
Vascularity, yeah. Secondaries also has a vascularity. So primary tumor mainly it is again arterial supply, hepatic artery supplies that, so you will take it then. All secondaries will be only on the portal in supplies that. So it's the late portal phase you will get. So that's one way we will be able to differentiate. So as ultrasound and CT, so node ultrasound can pick up early, but isoechogenic nodes, the nodes with the same echogenic surrounding may not be picked up by the ultrasound, so help you with that. And adherent to the neighboring structures, penetration to the pancreas, and other things will be the CT will be able to help you to get into a more delineation.
Which are some of the findings we may get in such cases? So which are the contraindication for your surgical management?
Surgical.
Sir, multiple mass lesions.
Multiple?
Multiple.
What is the CT finding?
Sir.
No, you describe the CT.
Yes, sir, there is a large. So shall I show the CT finding reporting or sir? Yes, sir. There is large mass in the left lobe of liver with the hypoechoic area within, sir.
Okay, go ahead.
How do they say it is a malignancy? Any CT finding, how do it says it's a malignancy? Why not it is a hemangioma? Okay.
How the CT will differentiate hemangioma from the hepatoma?
Hemangioma, sir, will have rapid early phase enhancement and rapid
take up and rapid washout.
Yes, sir.
Goes more in favor of a hemangiomas.
Can it be
rapid
a focal
take up
nodular
and delayed washout goes more in favor of a malignancy.
Can it be a focal nodular hyperplasia?
Yes.
Yes, sir.
How will you differentiate it from? No, okay. Read your CT findings. You are not able to describe it.
Yes, sir.
So, okay, how will you proceed this case?
Sir, further we will go for the biomarkers as the mass is in the liver, sir.
What are the markers?
So alpha fetoprotein, I would like to. And
for what?
Yes, sir.
For what we are going to do alpha fetoprotein?
Sir, for hepatocellular carcinoma.
Can any hepatocellular carcinoma can come without alpha fetoprotein?
Do they have any diagnostic value? Do they have any diagnostic value? Marcus, what you are asking for?
Yes, sir. So alpha fetoprotein, if it is raised more than 400, then it will be conclusive of hepatocellular carcinoma.
Okay.
No. Can you differentiate that from cholangiocarcinoma and hepatoma? And what is the peculiarity of the fibrolamellar carcinoma? So fibrolamellar carcinoma is a type of hepatocellular carcinoma which will not have the alpha fetoprotein.
So right. The normal levels.
It will be in the normal level. Oh.
Okay, sir.
Then the mark only alpha beta protein only will prove.
Sir, PIVCA.
PIVCA.
Yes, sir.
If there is any role of CEA?
Yes, sir. CEA.
What are you suspecting?
Yes, sir. Pardon, sir.
What are you suspecting? If you ask for CEA levels?
Sir, the carcinoma from the, sir, very, sir.
It is a secondary, so no colorectal.
Yeah, in the primary tumors of the liver, there is no much role. When you're suspecting a metastasis, particularly more so from the colorectal, then there is a need for going for a CA levels. Now, that too for the prognostic, not for the diagnostic purposes. They have got more of a prognostic value other than diagnostic. Then one more additional CT findings, if you happen to see the portal vein thrombosis, which can be made out on a contrast enhanced CT, they becomes an absolute contraindication for surgical resections. Okay. Whenever you're planning for surgical resection or planning for that, you have to make sure that portal veins are not thrombosed. If there are thrombosis, is one of the contraindication for surgical resections.
Yes, sir.
The thrombosis from the hepatic venous outflow into the IVC. This can be also made out. This is one of the relative contraindications, but not an absolute contraindication. These two are the additional findings you have to look for whenever you are planning for a CT scan with an intention to stage the disease as well as for the resection purposes.
Yes, sir.
Got it. What about the role of needle biopsy?
Sir, we do not do biopsies in.
Why? Whenever you plan for resection, it is mandatory, no? Everywhere.
Yes, sir.
Why you don't want to do it here?
Staging will change, sir.
Staging will change.
Staging will change.
How?
With FNAC.
No, what your answer said, it is right. Why you don't want to do needle biopsies?
And what is the complication you are going to get?
Suppose if you do it, then what are the complications?
And if you want to do it, and what are the precautions you take? So have you prepared for your hepatocellular carcinoma management treatment schedule?
Yes, sir.
What is the criteria? What are the treatment options you have?
Looking at the CT findings, it is the localized disease. Probably it could be an ideal case for resections. Looking at your CT findings, would you like to do a needle biopsy in this case?
No, sir.
No. Generally, in a potentially resectable liver diseases, liver malignancies, FNAC is not at all required. It is a contraindication in other sense. For the risk of a needle seedling, which is quite common in a hepatocellular carcinoma. If your image studies shows that it is a resectable disease, generally FNAC or needle biopsy is a contraindication. You have to plan your management on the CT images itself.
Yes, sir.
This is holds true even in renal cell carcinoma also. It holds true even in testicular carcinoma also. Okay, these are the diseases where the management is purely based on the image studies.
Yes, sir.
There are indications for needle provided.
Retroperitoneal tumors also.
Retroperitoneal tumors. One more retroperitoneal tumors. So there could be indication provided your image shows that it is an unresectable disease or an advanced disease or a metastatic disease. In such cases, needle biopsy is indicated for the management purposes. You need to differentiate whether it is from a carcinoma or a sarcoma or something else or neuroendocrine tumors. Depending upon your needle biopsy pathology, your management differs. For that reasons, FNAC is required. Otherwise, generally, ideally resectable disease of the liver masses, in a malignancy, there is no indication for a needle aspiration or needle biopsies. Got it? In general.
How will you assess this tumor is resectable? What are the criteria you have?
Yes, sir.
You are aware of Millen score?
Yes, sir. Millen scoring for yes, sir. The single tumor with less than 3 centimeters, sir.
Yes.
Yes, sir. 3 or less than 3 tumors. Yes, sir. No.
None more than 5 centimeter.
Yes, sir.
So you think by the CT scan finding this is the resectable one?
It does not look resectable.
Why?
It is. It looks advanced with tumor size is very big.
What should be the minimum segments to be there? Liver is always based on a segmental resection, no?
Yes.
What should be the minimal segments in order to have a normal liver function later?
In cirrhotic liver, sir, it should be 50%.
Yes.
And in normal, it should be 25%.
Yeah, in cirrhotic livers, you need to preserve more liver masses. Okay. Yes. In non-cirrhotic livers, even around 3 segments. Around 3 segments could have been, minimum should be there in order to have a normal functions.
So if you are, one possibility is a resection, what are the other options you have? Any technique of ablations you can do?
Yes, sir.
What are the ablative techniques you know?
Sir, arterial.
What is TACE? What is TARE?
Yes, sir.
Transarterial
transarterial chemoembolization. Yes, sir.
So what is the drug you use and how do you, what are things you do?
For
so TACE, TARE, what you use, radius ablation? Oh. So that is not amenable. Suppose so possibility of only, what is the next option? All these are not there.
Then
what is the best option here?
Sir, we can go for palliative management with chemo.
No. So transplantation. Can you do a transplantation?
Yes, sir. Yes, sir.
Okay. How will you assess the patient whether he is fit for transplantation? Or this? How will you prioritize the case for transplantation?
Any scoring system you follow here?
Child-Pugh score is there, sir. And
Child-Pugh score is different, huh?
Yes, sir.
That is for general the liver function. Of course, the Child-Pugh score should be A or B. What is MELD score?
MELD score.
So if at all you have allowed to do transplantation, what transplantation you will do? Okay. So we are getting late also. So hepatocellular carcinoma, if you are suspecting, because you know that, then you must study on the various options you have. At least if you are not going to the entire detail, the various scores which is there and how you are going to do the transplantation, what are the steps, basic steps in the transplantation, and what are the modalities of treatment, advanced modalities of the treatments available with that. And you must know also the differentiation of the fibrolamellar carcinoma, which is an entirely young age group we are going to get, especially in a male young age group without many contraceptive pills or the cirrhosis, you will get a fibrolamellar carcinoma. So that you should know, and you must know also how to differentiate on the focal nodular hyperplasia and the fibrolamellar carcinoma. What are the various changes which you are taking? And considering about the benign lesions also, there will be more questions on the hemangiomas and adenoma of the liver and how you are going to take. So please do not bring both clinical liver abscess and malignancy as a single go as a differential diagnosis.
Yes, sir. And
clinical finding with your GI tract symptoms, with the constipation, melena, and try to put carcinoma stomach as the first diagnosis and liver as a second possibility, because you are left-sided lesion you are going to take. Ishwar sir, you can tell us, we will close for the
No.
Kanavil sir has come. Kanavil sir?
Yes, sir, you can. Kanavil sir?
Yes, just joined.
Sir, I'm here.
Okay, I think we can close, sir.
Yes, sir. Yes, sir. Yes, sir. I've been watching. Thank you. Sushant, do you have any questions? I think Karnakaran sir has been quiet. Do you would like to add anything, sir? Okay. So, sir, faculty, can we call a close?
Yes, sir. Sure.
Yes. Ishwar sir, if possible, kindly permit one of your PGs for next week, sir. I will ask Jawahar sir the subsequent week,
Yes,
sir.
Okay. Sure, sir. Sure, sir. I'll do it.
Thank you very much. Sushant, do you have any questions to quickly clarify?
Sir, if the mass is extending from liver and it is more in epigastric region and we are suspecting it is gastric mass or hepatic mass. So on percussion, if it dullness is continuous with liver dullness, so can we differentiate on basis of percussion that it is not from gastric mass or?
See, earlier in examination findings are complementary. You don't go by one investigations. See, generally, there are other techniques which normally are not adapted. Patient in lateral position, patient in knee chest position. These are not generally expected from a postgraduate. But if you are not sure whether the tumor is abutting the liver or arising from the liver, generally turn the patient to the right side. Usually the stomach and liver will get separated. Percussion is very difficult, especially see if you have a huge antral growth or huge body mass, it's very difficult to say whether it is because both moves with respiration. It's quite difficult. As well, generally liver, it is quite rare to have an isolated thing if it is a secondary. Primary, as you say, will be a confusion. Secondary, you will have other telltale evidence of the remaining lobe. That is where we are going to differentiate. But percussion alone will not be a parameter for it.
Generally,
sir, any other points you'd like to add, sir, in this?
In a suspecting stomach, it is very uniformly dull is unlikely, sir. It could be a mixed. There could be resonant or some amount of air could have been there. However, the mass is big. You will always get the mixed type of notes in the when suspected the stomach as a possibility. If it is the liver, uniformly you could have a dull note. Generally.
One more thing, unless it is a gastrointestinal stromal tumor, this big tumor in the stomach would definitely have systemic manifestation. Stomach is quite, what to say, aggressive tumor for this huge mass to be quite. And the symptomatology totally differs. This huge mass in stomach presents with something totally in gastric symptoms, right?
Yes.
So it is a corroborative thing on clinical grounds. That is where you are welcome to give differentials. Faculty will accept a reasonable differential. Then you can take it further.
We fully agree on that, but the way you present it should be also like that. The explanation and the symptoms which you are talking. But you are unfortunately you have brought in the 20 days history. You are bringing in a melena, which you are not sure because again you are saying there is no blood into that. But there is no nausea and vomiting. That means there is no obstruction there. So all that features with that you couldn't have explained it properly. If you are explaining that, definitely the dullness, incontinuity of the liver dullness is more in favor of the liver mass. And as Aishwar has said, most of the time in the stomach mass, we will get only a impaired resonance. And such a big mass without producing any satiety, without producing any obstructive symptoms, you will not put it as a priority to that. But that all depends how confidently, how you are presenting the case, how you are explaining your situation.
They present, they should not know, present as if they do not know the findings, the investigative findings. Then only they will come to a differential diagnosis, they will justify the diagnosis. As know the findings.
That is true, sir, but I am surprised knowing this as a hepatocellular carcinoma, you have come without preparing for hepatocellular carcinoma.
That is second point.
So you should have come little more time you should have spent on studying that. And the order in which you are presenting the case, never ever change that pattern. So do an inspection and palpation, percussion, special examination, systemic examination, then you go for a diagnosis. That is a examiner sometimes they want a small alteration, they won't accept that.
Sushant, if you finish reading liver, you will be done with 3 or 4 long questions and at least 10 shorts. One major thing will be over, right? So liver chapter is very, very crucial. You have multiple long questions. Hepatocellular carcinoma will be a long question. Management of secondary liver will be a long question. Now, very modern thing question, but there will be a transplant question always in one of the 4 papers what you guys are writing. So liver chapter is
Liver
very
resections
crucial.
also.
Sorry, sir.
Liver resections also. There will be some questions
Sir.
on liver resections.
Anatomical segments, RF ablation, TACE, like ALPS, like that specific newer techniques. Then more so, tumor markers will be a question. And then you will be asked to tell about portal hypertension. There will be one question or something, either with the spleen. Shunts will be a question. Invariably, if you finish liver, you have finished a huge segment of it. So please sit and study, all of you students here. Liver is very, very important. Many GI tract are covered under liver. So you also should read about TIPS. TIPS is no more done, but then TIPS will be a standard question one should be aware when you are asked to write about the shunts. And so newer techniques of doing liver biopsy, transjugular, all those things have to be done. And you also should understand US guided staging for the liver is another short note one should be aware, because they have a totally different perspective. And then vascular complications of portal system also is a separate question. Portal cavernoma is a short note. You have huge number of questions. Students should concentrate on liver chapter, because liver chapter you complete, you will be assured of 1 or 2 long questions and 1 or 2 short questions for sure.
And on the parasitic cyst, hydrated cyst of the liver,
Hydrated liver abscess.
Cystic disease of the liver, again, one big question. Then among the pyemic liver abscess can be abubic liver abscess, and then some metabolic disorders. So common, what Sir Cultivar sir said, Kanagwell, if you prepare liver, 25% of your questions are ready almost.
Basic, the child score and milk score, all very, very important, commonly used. So you Milan score, all that you just get updated.
Then one should be familiar with the anatomy of the segments of the liver. Cunard segments.
Coinads
You
will
have
be
to name the
question.
segment. You should know the definition of trisegmentectomy, bisegmentectomy, extended right hepatectomy. All these terminology one should know whenever you make a diagnosis of hepatoma. Then Canty's lines, and then CT findings, contrast. All these things are very important for the postgraduate level of discussion.
Good luck to
Anyway,
you, Sushant.
Thank you so much, sir. We'll definitely prepare
Actually,
for
as all the
next
faculty has been
videos.
telling, this is time to only to restock your situation. Nothing wrong. You restock, work harder, go back to the basics, go back to the textbooks, read one time the liver chapter. One textbook is never sufficient for liver. Some textbooks concentrate on benign, some textbooks concentrate on infectious. If you can have time, Schlesinger's gastroenterology gives a very extensive review of liver diseases. All students should take time off to read Schlesinger's. All right.
Yes,
sir. Jawahar sir, Jailal sir, Ishwar sir, can we call a close, sir?
Yes, sir, please.
Yes, sir, please.
Thank you very much, students.
So,
we
you are
look
reached,
forward for yet another.
You are reached which place, sir?
Sorry, sir.
You are reached which place now?
Sir, I am last 3 days in the international conference, sir, Deep Impact Delhi. This place is this place suddenly the internet goes off, sir. Now I'm using hotspot to use that, sir. That's why I handed over. There is some problem with the broadband here, so now I'm okay. Sir. In between,
No, it's okay. Sir. No, it's absolutely fine.
Yes, sir.
Good.
You are in AWR conference?
Sorry, sir.
You are in AWR conference? Abdomen wall reconstruction conference?
Yes. It is a huge one, sir. 1,700 people have registered.
Yo.
We have faculty from 40 countries. A lot of and conference runs from morning 8 to evening 8. Sir. Their concept is totally American-like. So they are squeezing 4 days meeting, 5 days meeting into 3 days. So hectic, sir. Very hectic.
Okay.
400 papers. A lot of new things are also being discussed. New techniques also being discussed, sir. Anyway, happy to say that Chennai will be hosting the 2025 meetings, sir, International Congress.
Okay. Oh, congratulations, sir. A lot of work.
Thank you, sir. All of you should be there to help us, sir.
Sure, sir. It will be more than the crowd of Delhi.
Yeah, we would like to, sir. We would like to, sir. And we need all your support.
all of a sudden hernia has taken a very more important in our surgical life.
No, sir. I
Then,
think
number of cases are also increasing, sir. We are getting
definitely,
now,
sir. Number of cases are definitely increasing. No doubt about it.
sir, like that is one modality, even in the United States, general surgeons have a total control of it, sir. Because
Yes.
this is one specialty, the general surgery department has a huge role. Because
Even
nowadays,
in India
the
also, sir.
sections
Why
are-
not in abroad? Even in India.
No, sir. Actually, I have to share something today, they said abdominal core health surgery is a separate department under general surgery now in US. Sir,
Yes.
435 hospitals have this abdominal core health surgery, sir. They do only hernia as a subspecialization under general surgery.
Okay,
So
fine, sir.
they have 435 fellowship qualified abdominal wall surgeons. So obviously we should catch up with that. But I think 80% of the work is general hernia work, sir. They also agree. 10 to 12% only is abdominal wall work. Other things are inguinal, ventral, all those common things only, sir.
How's the workshop going on, sir? Workshop also is there?
Sir, workshop we had, they have arranged at 10 different workshops, sir. 10 places, first day. So every hospital like Apollo, Maulana Azad Medical College, Gangaram, everybody they hosted, sir. So they had their own workshop. So I was in Maulana Azad, we had a hiatal hernia workshop. Like that, every hospital had their own workshop, sir. So later, today we had only sessions, 4 halls, 12 hours each. And then tomorrow again 4 halls, 12 hours each. Tomorrow they are going to have only 3 hours of live surgery of the newer techniques, sir. They have taken permission for the international faculty to operate. About 40 of them, NMC have granted permission. So few of them are going to perform tomorrow.
Operating also.
Yes, sir. So thank you, sir. Thank you very much for
thank
joining.
you, thank you.
Sushant and Abhijit, thank you for joining. And I thank Smriti ma'am and Jishan Ahmed ma'am for kindly contributing today. Good night.